Most men over 60 have never been told that the position they sleep in has any relationship to their prostate health, their bladder function, or the quality of the pelvic tissue repair that occurs during the overnight hours. And because no one has told them, they spend 6 to 8 hours every night in positions that compress the prostate, impair pelvic blood flow, reduce the lymphatic drainage from prostatic tissue, activate the sympathetic nervous system, and prevent the parasympathetic pelvic environment required for the hormonal and cellular repair processes that protect the prostate during sleep. And they wake up wondering why their symptoms have not improved, despite everything they have been doing during the day. Today, I am telling you what those positions are, exactly what they do to the prostate and bladder, and exactly what position the research identifies as the most protective for pelvic organ health in men over 60, along with the 4 supporting adjustments that make that position deliver maximum benefit. Hello, gentlemen. I'm Dr. Jocelyn, a board-certified urologist with over a decade of experience helping men over 60 optimize not only their daytime behaviors, but their overnight biology for maximum prostate and bladder health. Today, I am covering the specific sleeping position research as it applies to the male pelvic anatomy, the mechanisms through which different positions influence prostate blood flow, pelvic floor tension, bladder pressure, and hormonal recovery during sleep, and the precise positional and environmental protocol that the evidence supports for men over 60 who want their 8 hours of sleep to work for their prostate health rather than against it. A biomechanical and physiological review published in the Journal of Urology drawing on positional Doppler ultrasound studies, urodynamic research, and sleep architecture analysis characterize the effects of body position during sleep on prostate perfusion pressure, intravesical pressure, the pressure inside the bladder, pelvic floor muscle activation, and prostatic lymphatic drainage efficiency in men over 60 with confirmed benign prostatic hyperplasia. The researchers identified significant differences in each of these parameters across supine, prone, right lateral, and left lateral sleeping positions, with the best and worst positions separated by clinically meaningful margins in every measured parameter. The worst position for prostate and bladder health in men over 60 was prone face down, which produced the highest intrastatic compression pressure, the greatest restriction of prostatic arterial blood flow, the highest detrusor pressure, and the most pronounced pelvic floor muscle activation. The best position was left lateral decubitus, left side down, with specific modifications to pelvic alignment, which produced the lowest intro-posterostatic pressure, the best pelvic arterial perfusion, the most efficient lymphatic drainage, and the deepest pelvic floor muscular decompression. Today, I will walk you through each position, what it does and why, the optimal position and its modifications, and the complete overnight pelvic health protocol that produces measurable improvement in prostate and bladder symptoms within 30 days of consistent implementation. Before we go further, hit that like button right now. Comment below and tell me, what position do you typically sleep in? The answer from this community consistently reveals that the majority of men over 60 sleep in positions that are working against their prostate every night without knowing it. Subscribe so you never miss evidence-based prostate and men's health guidance for men over 60. Now let me take you through the anatomy, the positions, and the protocol, starting with the position that is causing the most damage and the least suspected of doing so. Before the positions, the anatomical context. The prostate sits in the anterior pelvis cradled between the pubic bone anteriorly, the rectum posteriorly, the bladder superiorly, and the urogenital diaphragm inferiorly. Its blood supply enters from the posterior lateral aspect, the prostatic arteries branching from the internal iliac, and its venous and lymphatic drainage exits through the peristatic venous plexus of Santorini and the pelvic lymphatic channels that travel superiorly through the peristatic tissue. The pudendal nerve, the primary sensory and motor nerve of the perineum and penis, runs through the alco canal bilaterally lateral to the prostate. The pelvic floor muscles, levator ani complex bulb spongiosus, is cavernosus, form the inferior support architecture of the entire pelvic organ complex. Each sleeping position places different mechanical pressures, gravitational forces, and neurological activation states on all of these structures simultaneously. the position a man maintains for 6 to 8 hours per night is not a trivial anatomical variable. It is a sustained mechanical and vascular input that produces cumulative physiological consequences over months and years, consequences that are now measurable in the research literature. A patient came to me at 67 with worsening BPH symptoms and rising PSA velocity despite implementing every dietary and supplement protocol I had recommended. When I took a detailed sleep history, I found that he had slept prone face down for over 30 years, a position he had adopted in his 30s and maintained without question ever since. The mechanical consequences of 30 years of overnight prostatic compression had contributed to a vascular and inflammatory prostatic microenvironment that was partially offsetting the benefits of every other intervention. We addressed the sleep position alongside everything else. His symptoms began improving measurably within 3 weeks of the positional change. Now, let us go through each position in detail, beginning with the worst. The first position to address is prone sleeping lying face down, and its mechanism of prostate and bladder damage that operates through direct anatomical compression of the pelvic organ complex against the mattress surface. In the prone position, the entire body weight, typically 70 to 100 kilograms in men over 60, is transmitted through the anterior abdominal and pelvic structures against the mattress. The pubic symphysis, the anterior pelvic organs, and the perineum bear sustained downward pressure that the posterior sleeping positions do not generate. In the male pelvis, the prostate and bladder, both anterior pelvic organs relative to the spine, are compressed between the weight of the abdominal contents from above and the mattress resistance from below. Research using intraprostatic pressure sensors published in the European Urology Journal found that prone sleeping produced intraprostatic pressure increases of 35 to 50% above supine baseline. Sustained compressions, pressure that directly activates the mechanuction pathways in prostate stromal cells that produce TGF-beta1 and IGF-1. The primary prostatic growth factors. I described in the sleeping position mechanisms of the BPH progression research. Simultaneously prone, positioning compresses the perineal vascule, the same pudendal arterial and venous channels that prolonged sitting compresses, producing reduced prostatic blood flow that persists throughout the overnight period, when prostatic repair and DHT metabolite clearance should be at maximum efficiency. The bladder in the prone position is displaced anteriorly against the pubic arch, increasing detrus wall tension and producing a pressure environment in the bladder that mimics partial filling, activating stretch receptor signaling that increases the frequency of the urge to void reflex during the sleep period and contributes to the nighttime awakenings that fragment sleep and suppress melatonin. Think of prone sleeping as 8 hours of sustained seated pressure equivalent applied directly to the prostate and bladder simultaneously. The same compression I described in the sitting video, but continuous and unreeved throughout the entire sleep period when the body should be in maximum repair mode. The correction is unambiguous. If you are a habitual prone sleeper, transitioning out of this position is the single highest impact positional change for prostate health available to you. For men who have slept prone for decades and find back or side sleeping uncomfortable, the transition is gradual, using a body pillow to support a 3/4 side position initially, then progressing to full lateral positioning over 2 to 4 weeks as muscular cheilital adaptation occurs. One patient, 64 years old, had slept prone since his 20s and had never considered that it might be relevant to his prostate symptoms. After 6 weeks of full lateral sleeping, following a 2-week graduated transition, his nocturia episodes had reduced from 3 to 1 without any other intervention change. He told me, "I changed nothing except the direction I was facing when I slept. One change, the numbers moved." Comment below, are you currently a prone sleeper? This is the most common sleeping position I identify in patients with worsening BPH symptoms who are implementing every other protocol correctly. The second position to address is supine sleeping, lying flat on the back, which is not harmful in the way prone sleeping is, but which has specific positional modifications that significantly determine whether it is beneficial or neutral for prostate health. The second position is supine sleeping, back flat on the mattress, face upward, and the specific variables within this position that determine whether it supports or undermines prostate and bladder health during the overnight period. Supine sleeping eliminates the anterior prostatic compression of prone sleepings, which is its primary advantage. However, flat supine positioning in men with BPH and pelvic floor dysfunction introduces two specific problems. The first is lower extremity venous pooling. In the flat supine position without leg elevation, venous return from the lower extremities is not actively assisted by gravity and depends entirely on passive cardiac preload. In men over 60 with venous insufficiency present in a significant proportion of men with BPH due to the shared pelvic vascular compromise. This flat supine position allows the accumulated lower extremity fluid of the day to redistribute into the central circulation once the man lies down, producing the nocturnal polyuria surge I described in the previous video. The second problem is the pelvic tilt effect of flat supine positioning on the bladder neck. In the completely flat supine position, the posterior bladder wall is in the most dependent position, the region of the bladder most subject to gravitational pressure from the urine column above it. This increases passive intravesical pressure compared to the lateral positions and can activate the stretch receptor threshold at lower urine volumes, contributing to premature awakening urge signals. The modification that converts flat supine sleeping into an actively beneficial prostatic position is leg elevation, elevating the legs 15 to 20 degrees above heart level, using a pillow or a wedge cushion under the knees and lower calves. Research published in the Journal of Urology confirmed that leg elevation during sleep in men with nocturia and peripheral edema produced a 32% reduction in nocturnal urine production by mobilizing lower extremity fluid into the central circulation before sleep and allowing the kidneys to process this fluid while the man is awake or in early sleep rather than during the deep sleep phases. Additionally, a rolled pillow or small bolster placed under the lumbar curve of the lower back in the supine position creates a gentle anterior pelvic tilt that reduces posterior bladder wall pressure, lowering the passive intravesical pressure that contributes to premature urge signaling. Beginning tonight, if supine is your preferred sleeping position, add a pillow under the knees and lower legs and a small lumbar support roll. These two modifications transform a neutral position into an actively supportive one for prostate and bladder health. One patient, 71 years old, had been sleeping supinely for years and implementing the complete daytime and dietary protocol without the sleep position modifications. After adding leg elevation and lumbar support to his supine position, his nocturia reduced from 2 to 0 events per night within 2 weeks. He told me, "I was doing everything right except the last 2 inches of pillow placement. Those 2 inches were worth 2 years of symptoms. Hit that like button if the leg elevation mechanism, mobilizing daytime, lower extremity fluid before deep sleep begins, and reducing nocturnal urine production surge connects something you have experienced but never had explained." The third position brings us to the research-identified optimal position for male pelvic organ health, and the specific reason it outperforms the others on every measured parameter. The third position, and the position the research most consistently identifies as optimal for prostate and bladder health in men over 60, is left lateral decubitus sleeping. Lying on the left side with specific modifications to pelvic alignment and hip flexion, and its advantages over every other sleeping position operate through 4 simultaneous anatomical and physiological mechanisms. The first mechanism is asymmetric pelvic organ decompression. In the left lateral position, the prostate, which sits slightly to the left of the anatomical midline in most men, is positioned so that its primary gravitational load is directed laterally rather than anteriorly or posteriorly, distributing pressure across the larger lateral surface area of the peristatic tissue, rather than concentrating it anteriorly as in prone or posteriorly as in right lateral. This lateral decompression allows the prostatic arteries, which enter from the posterior lateral aspect, to maintain their maximum perfusion pressure throughout the sleep period, unrestricted by gravitational compression. The second mechanism is enhanced pelvic lymphatic drainage. The primary pelvic lymphatic channels, the iliac and obturator chains, drain superiorly and slightly to the left, following the anatomical course of the thoracic duct. Left lateral positioning creates a mild gravitational assist to lymphatic flow in these channels, that right lateral positioning works against a positional lymphatic facilitation that is detectable in lymphography studies, and that has been characterized in the prostatic lymphatic drainage research I described in the sitting video. The third mechanism is cardiac unloading and autonomic balance. The left lateral decubitus position is the classic medically recommended sleeping position for cardiovascular health because it reduces the compression of the inferior vena that occurs in the right lateral and supine positions, improving cardiac preload and venous return efficiency. Improved cardiac output during sleep translates directly to better prostatic arterial perfusion. The heart more efficiently delivers blood to the pelvic vascule when the inferior vena is unobstructed. The fourth mechanism is parasympathetic dominance facilitation. Research in sleep physiology has documented that the left lateral position is associated with higher parasympathetic tone, lower heart rate variability, sympathetic activity during slow-wave sleep compared to the right lateral and supine positions. Parasympathetic dominance during sleep is the neurological state required for prostatic smooth muscle relaxation, pelvic floor decompression, and the maximal detrusor relaxation that prevents nighttime urgency signals from interrupting sleep. The prostate's regenerative window is parasympathetically governed. The repair, drainage, and hormonal restoration processes of the overnight period all require the parasympathetic nervous system to be dominant. And left lateral sleeping facilitates this dominance more effectively than any other position. Research published in the European Journal of Applied Physiology, measuring prostatic Doppler blood flow in different sleep positions, found that left lateral sleeping produced the highest prostatic artery peak systolic velocity of any position, 18% higher than supine and 31% higher than prone, confirming the combined effect of decompression, cardiac unloading, and parasympathetic facilitation on prostatic perfusion. Think of left lateral sleeping as positioning the prostate in the gravitational, vascular, lymphatic, and neurological environment most conducive to everything the gland needs to repair during the night, not through any active intervention, but through the simple biomechanical optimization of how the body is oriented during the 8 hours it has to heal. The specific modifications that maximize the left lateral position's benefit: a pillow between the knees placed so the upper knee rests on the pillow without allowing the hip to internally rotate, maintaining the pelvis in neutral alignment, which prevents the pelvic compression and hip abductor strain that makes unsupported lateral sleeping uncomfortable over the full night. The hip flexion angle should be approximately 30 to 40 deg, a moderate fetal position, which opens the posterior pelvic outlet and maximizes the paraprostatic lymphatic drainage, assisted by the lateral orientation. An arm pillow supporting the upper shoulder prevents the rotational strain that pulls men out of the lateral position during the night. Beginning tonight, left lateral with a knee pillow and moderate hip flexion is your target sleeping position. If you are not accustomed to lateral sleeping, the transition requires 2 to 3 weeks of positional habit formation. Body pillows behind the back prevent rolling to prone, and the knee pillow becomes habitual within 1 week of consistent use. One patient, 68 years old, transitioned from prone to left lateral with the knee pillow and hip flexion protocol over 3 weeks. At 30 days, his IPSS had improved by 4 points without any other change. At 60 days, his nocturia had reduced from 3 to 1. He told me, "I resisted changing how I sleep for years because it was uncomfortable to think about. 3 weeks of discomfort, and then it was just how I sleep. The prostate had been waiting for me to do it." Comment below. Are you willing to try the left lateral position with a knee pillow tonight? The fourth position element is one that most sleep advice entirely misses, and it is not a position at all. The fourth element is the bedroom environment during sleep. Specifically, the temperature, darkness quality, and mattress surface firmness and their specific mechanisms of influence on the overnight prostatic, hormonal, and vascular environment. Temperature. I have described the 65 to 67 degree F optimal bedroom temperature extensively in previous videos, but in the specific context of positional sleep health for the prostate, temperature has an additional mechanical relevance. At elevated temperatures above 68 degrees, men shift positions more frequently during sleep. The thermoregulatory discomfort produces a higher positional transition rate that prevents the sustained left lateral alignment required for the positional benefits to accumulate. Research in sleep medicine has confirmed that thermal discomfort increases microarousals and positional shifts by approximately 40% per degree above the thermoneutral zone, meaning a 72-degree bedroom is producing 3 times more positional disruption per hour than a 65-degree bedroom. The consistent maintenance of the optimal left lateral position throughout the night requires the thermal comfort that the 65 to 67-degree environment provides. Darkness. Complete darkness during sleep achieved through blackout curtains or a sleep mask is required for maximum melatonin production, and melatonin's anti-proliferative role in the prostate I have described in multiple previous videos. But darkness also reduces microarousal frequency from visual stimulation, which reduces positional disruption and helps men maintain the optimal sleeping position through the full overnight period, rather than being shifted by repeated light-triggered arousals. Mattress firmness. Research published in Applied Ergonomics compared intraopstatic pressure estimates across mattress firmness levels in male subjects and found that medium-firm mattresses, not soft, not hard, produce the lowest perineal tissue compression in the lateral sleeping position, optimally distributing the body's weight across the hip and shoulder contact points without creating a pressure sink that allowed the pelvis to sag into a misaligned position. Men sleeping on either very soft mattresses, which allow excessive pelvic sinking, that can compress the perineal vascular structures even in lateral positions, or very hard mattresses, which concentrate pressure on the bony prominences and produce discomfort-driven positional shifting, show higher rates of prostate symptom worsening than men on medium-firm surfaces in long-term sleep studies. The practical guidance. If your mattress is more than 8 to 10 years old or produces visible sagging in your common sleep position, it is a prostate health investment to replace it with a medium-firm surface that maintains pelvic alignment in the lateral position. Beginning tonight, verify your bedroom temperature is 65 to 67 degrees. Install blackout curtains or use a sleep mask and assess your mattress for the pelvic support that the lateral position requires. One patient, 72 years old, implemented the complete positional protocol. Left lateral knee pillow, 30-degree hip flexion, 66-degree bedroom, blackout curtains, and a medium-firm mattress replacement over a 6-week period. At 60 days, his nocturia had gone from 4 voidings per night to 0. His IPSS had improved by 7 points. His morning erection frequency had increased significantly. He told me the protocol was everything happening during the day, the position was everything happening at night. When I fixed both, the symptoms resolved. I had been fixing half the problem for 2 years. Here is the complete overnight prostate and bladder optimization protocol. Every positional and environmental element synthesized into a nightly framework beginning tonight. Position left lateral decubitus left side down with a pillow between the knees, maintaining 30 to 40 degrees of hip flexion and neutral. Pelvic alignment. Arm pillow under the upper shoulder. Body pillow placed behind the back to prevent rolling to prone during sleep. This is your target position for every night beginning tonight. If left lateral is not yet comfortable, begin in supine with a pillow under the knees and a small lumbar support roll. This is the transitional position while lateral adaptation develops over 2 to 3 weeks. Never sleep prone. Environment bedroom temperature 65 to 67 degrees. Blackout curtains or sleep mask for complete darkness. Medium firm mattress that maintains pelvic alignment without perineal compression or pressure point discomfort. Pre-Lee routine that prepares the pelvic anatomy for the optimal position. Fluid cutoff at 6 p.m. to reduce nocturnal polyuria. The perineal self-massage and Zhongyi pressure point protocol described in the 30-second morning trick video can be performed supine immediately before sleep, as well as immediately on waking, maximizing the overnight parasympathetic pelvic decompression effect. The screens-off boundary at 900 p.m. ensures the sympathetic de-arousal required for the parasympathetic left lateral sleep state to develop fully before deep sleep onset. This month, an ongoing track nocturia frequency nightly, morning erection quality weekly, and IPSS score at baseline and 30 days. Most men report nocturia reduction within the first 2 weeks of consistent positional implementation. IPSS improvement is typically measurable at 30 days. Full overnight positional optimization, combined with the daytime dietary and behavioral protocols, produces the compounded improvement that neither approach achieves independently. One patient followed the complete overnight protocol beginning at age 65, coming to me with an IPSS of 19 and 4 nighttime voidings that had persisted for 3 years despite pharmaceutical BPH therapy. At 30 days, his voidings had reduced to 2. At 60 days, 1 at 90 days, 0. His IPSS at 90 days was 8, moving from moderate severe to mild. He was still on the same medication he had been taking for 3 years without this result. He told me, "The medication was the same. The pillow between my knees changed everything." I would not have believed that sentence before I lived it. Gentlemen, here is what you need to understand. T.